I want you to imagine, just for a moment, a really high-stakes structural engineering problem.
Okay, I'm picturing it.
But instead of picturing, like, a massive suspension bridge spanning a gorge, or some skyscraper engineered to sway in hurricane winds, I want you to focus in on something much more intimate. Think about the clear window of your very own eye, the cornea.
Yeah, which is, without exaggeration, one of the most mechanically demanding structures in human anatomy
Right.
because it has to maintain absolute optical transparency, to let light through without scattering it. But at the same time, it has to remain rigid enough to hold its exact curvature against the constant pushing internal pressure of the eye itself. It's essentially a biological pressure vessel.
A biological pressure vessel. I love that description. And today, we are unpacking a mini review that looks at exactly what happens when that pressure vessel starts to fail.
And the incredible lengths that ophthalmologists have gone to in order to fix it.
Exactly. We're doing a deep dive into a really comprehensive paper authored by Pradeep Dubey and Bithi Chowdhury. This is from the Hindu Rao Hospital and NDMC Medical College.
And what makes this specific review so compelling isn't just, a catalog of surgical techniques. It really serves as a historical record of a decades-long battle against this seemingly impossible medical paradox.
Yeah, reading through it, it's wild.
It is. The authors meticulously document how the field basically ran headfirst into a rigid biological wall and how surgeons had to completely rethink the physics and chemistry of the eye to get around it.
And that paradox is the core mission of our deep dive today.
Yeah.
We are going to figure out how modern ophthalmology solved a massive catch-22.
A very literal catch-22.
Right. So the treatment we're discussing is called corneal cross-linking, or CXL for short. It was specifically developed to save eyes that are thinning and bulging outward, conditions like keratoconus.
Which is a terrifying condition for a patient.
Absolutely. But here is the brutal irony of the whole thing. To safely undergo the very procedure designed to save your rapidly thinning cornea, your cornea originally needed to be thick enough to survive the treatment.
You're hitting on the exact problem that defined all the early interventions. The disease inherently destroys the structural integrity required to endure the cure.
It's like needing to be healthy to take a life-saving medicine.
Exactly. So today we're going to look closely at why those hard physiological boundaries exist, the biophysics of ultraviolet light interacting with tissue, and really the ingenious, highly technical workarounds surgeons have engineered to bypass those limits safely.
Okay, let's unpack this. Because to understand how the medical community eventually broke the rules for these ultra-thin corneas, we first have to establish the foundational biochemistry of how we make an eye stiff in the first place.
Right, the basic mechanism of action.
Yeah. And looking at the history in this paper, the concept of photosensitized oxidation, using light and a chemical catalyst to alter biological tissue, that goes back way further than the modern laser eye surgery era.
Oh, entirely. It dates all the way back to 1968.
1968.
Yeah, and the early applications were strictly mechanical and non-ophthalmic. Researchers were utilizing these cross-linking mechanisms to stiffen cardiac valve prostheses and for general tissue fixation.
So not even for living eyes yet, just
Right.
prepping biological material.
Exactly. The goal was taking organic biological material and rendering it structurally durable enough to act as a permanent, non-degrading implant in the human body.
Wow. So the leap to the eye took decades. It wasn't until 1998 that Sporl published data demonstrating this cross-linking process in the corneal tissue of porcine models.
Right. Pig eyes.
Hey guys, yeah. And then finally in 2003, Wollensack brought the combination of riboflavin and UVA irradiation to human trials. But it took all the way until 2016 for the FDA to actually grant approval for treating keratoconus and post-LASIK ectasia.
Which is a massive gap.
Yeah.
That 48-year gap between concept and FDA approval speaks volumes about the extreme caution required when manipulating the visual axis. You really don't want to mess with the eye unnecessarily.
Absolutely not.
But to fully grasp what Wollensack's team achieved, we really have to look at the stromal architecture. The cornea is not just, a homogeneous piece of biological glass.
Right, it has layers.
Exactly. The stroma, which makes up about 90% of its thickness, is this highly complex matrix of tightly interwoven collagen fibrils.
And the mechanical strength of that entire matrix depends on the intermolecular crosslinks between those collagen monomers. Right? It's basically the biochemical scaffolding.
That's a great way to picture it.
But what blew my mind reading through the background here is that this cross-linking isn't just some surgical invention. The human body naturally executes this process in a few distinct ways.
That's a crucial point to understand. The first natural mechanism is enzymatic. So throughout human development and tissue maturation, our bodies rely on an enzyme called lysine oxidase.
Okay.
And that enzyme catalyzes the formation of these structural bridges between collagen molecules. It's a fundamental biological building block for connective tissue all over the body.
Okay, but the second natural method is where we start seeing real-world clinical implications that overlap with the surgery, and that is glycation.
Yes, glycation. This is the formation of advanced glycation end products, or what we call AGEs.
Right, so what exactly is glycation on a chemical level?
Well, glycation is a non-enzymatic process where reducing sugars covalently bond with the amino groups of proteins. In the cornea, this leads to the formation of compounds like pentosodine.
Okay, pentosodine.
And then these compounds create these really tough covalent crosslinks between specific amino acid residues, primarily arginine and lysine, across neighboring collagen fibrils.
Okay, so if you're listening to this and wondering what glycation looks like in practice, I was thinking about it like candying a piece of fruit. You know, you soak it in sugar and it gets rigid.
That's actually a very accurate analogy.
Yeah, and you see this clearly in diabetic patients. Because of chronic hyperglycemia-like elevated blood sugar levels, they have a massively accelerated rate of AG formation.
Right, their bodies are essentially bathed in excess sugar.
Exactly. And it acts like a systemic stiffening agent. It's actually why the corneas of diabetic patients and elderly patients to a degree are measurably more rigid. The sugar essentially locks the collagen matrix into a tighter, stiffer conformation.
It is a highly accurate representation of the biochemical pathway. You are introducing glucose, the chemical reaction takes place, and the extracellular matrix loses its elasticity. It stiffens up.
Okay, so that's natural stiffening. But the third method of cross-linking, and the one that the CXL procedure entirely relies upon, is oxidation.
Right. Clinical targeted oxidation. In CXL, doctors are artificially inducing a rapid oxidative state.
How do they do that?
Well, they saturate the tissue with riboflavin.
Which is vitamin B2, right?
Exactly. It acts as the photosensitizer. And then they hit it with ultraviolet, a light. This is designed to immediately halt the progression of ectatic diseases, where the stroma is deteriorating and the internal pressure of the eye pushes the cornea out into a sharp cone.
So when you combine the riboflavin and the UVA irradiation in the presence of molecular oxygen, you trigger this photochemical reaction, right?
Yes, it generates reactive oxygen species, or ROS. These are singlet oxygen molecules, and they are incredibly unstable and highly reactive.
So they just start grabbing on to whatever is nearby.
Pretty much. They aggressively seek out surrounding molecules, forcing new covalent bonds to form between the collagen fibrils and the surrounding proteoglycans. It rapidly and artificially fortifies that shifting, bulging cornea.
Which brings us to the original gold standard for executing this chemical reaction, the Dresden Protocol.
Yes, the famous Dresden Protocol.
For years, this was the absolute, unquestionable roadmap for saving these eyes. And man, it is a notoriously intense procedure.
It is biologically taxing by design. According to the foundational parameters established by Wollensack, the Dresden Protocol has 3 really rigid phases.
Walk us through them.
First, the surgeon must perform a complete epithelial debridement. They mechanically scrape away the central 8 to 9 millimeters of the epithelium, which is the cornea's outermost cellular layer.
Which sounds absolutely brutal, scraping the surface of the eye.
It's not pleasant, but it's chemically necessary. Riboflavin is a relatively large hydrophilic molecule. That means it loves water.
Okay.
But the epithelium is a highly lipophilic barrier. It loves fats, and it's designed specifically to keep water-soluble substances out of the eye. So if you don't remove that protective skin, the riboflavin simply cannot penetrate deep enough into the stroma where the collagen actually needs the structural reinforcement.
Ah, okay. So the skin acts as a shield against the drug, so you scrape it off.
Precisely. Once the stroma is laid bare, step 2 involves saturating that exposed tissue with an isoosmolar riboflavin solution. And they do this for a full 30 minutes to ensure adequate diffusion throughout the entire stromal depth.
Just letting it soak in?
Yes. Finally, step 3. The eye is irradiated with a continuous UVA light at an intensity of 3 milliwatts per square centimeter for another unbroken 30 minutes.
That is a long time to have a UV light shining directly into your eye. And this is exactly where we hit the biological wall, because the absolute non-negotiable limitation of the Dresden Protocol is the 400 micron rule.
Right.
The literature strictly dictates that after you scrape off the epithelium, the remaining stromal bed must be at least 400 micrometers thick.
To put that in perspective for you, 400 micrometers is barely 4/10 of a millimeter. It is incredibly thin.
Barely visible.
But in the highly compressed real estate of the anterior segment of the eye, that specific measurement is the absolute mathematical boundary between success and permanent blindness.
And that boundary exists because of the endothelium, right?
Yes, the endothelium. It is the innermost monolayer of cells in the cornea.
Just a single layer of cells?
Just one layer, and crucially, it does not regenerate in humans.
Wow. So once they're gone, they're gone.
Exactly. Its primary function is to act as a physiological pump. It's constantly drawing fluid out of the stroma to maintain that perfect optical clarity so you can see.
Like a bilge pump on a boat.
Exactly like a bilge pump. If the UVA irradiation penetrates too deeply and induces oxidative damage to those endothelial cells, they die off. The pump fails.
And then the eye floods.
Yes, the stroma fills with fluid. It becomes massively swollen and completely opaque, and the patient suffers irreversible vision loss. At that point, they require a full corneal transplant.
So basically, the 400 microns of stromal tissue essentially acts as a biological sponge. It needs to be thick enough to absorb all the harmful UV energy in those reactive oxygen species before they can reach the basement floor where those endothelial cells live.
That's exactly how it works. The protocol was calibrated so that at a depth of 400 microns, the UVA irradiance is attenuated down to about 0.18 milliwatts per square centimeter.
Which is the safety limit.
Yes, that is the established cytotoxic threshold for the endothelium. Anything thinner than 400 microns, and that cytotoxic threshold is breached. The cells die.
Okay, so if the 400 micron rule is grounded in such absolute, undeniable biophysics, why was the field so desperate to find a workaround? I mean, if the Dresden Protocol is the gold standard, why do we need to change it?
Because of the cruel irony of keratoconus we discussed earlier, the defining characteristic of the disease is progressive stromal thinning.
The eye is literally getting thinner and pointier.
Exactly. So by the time many patients present at a clinic with active disease progression, meaning they are the exact demographic that urgently needs this cross-linking to prevent a transplant, their corneas have already thinned well below 400 microns.
Oh, man. So they are automatically disqualified from the only FDA-approved treatment that can save them.
It is a devastating clinical scenario. Sorry, your eye is too sick for the cure. And it is actually exacerbated by the procedure itself.
What do you mean?
Well, the 30-minute UVA exposure, combined with the riboflavin dextran solution, induces significant desiccation of the tissue.
Wait, so the procedure shrinks the eye while you're doing it?
Considerably. The intraoperative dehydration can cause the stroma to thin by up to 20% during the actual procedure.
20%, that's massive.
So a patient who barely clears the threshold, let's say they walk into the OR with a 410 micron cornea. They might drop to 350 microns halfway through the UV exposure, and suddenly you are actively exposing their endothelium to toxic radiation.
That is truly terrifying. You're subjecting a critically ill eye to a procedure that chemically demands a healthy thickness to survive. The standard procedure was just fundamentally unfit for the most vulnerable patients.
It really was. And that hard, unyielding boundary is what catalyzed an explosion of alternative surgical strategies starting around 2009. The field realized that if you cannot alter the cytotoxic threshold of the laser, because physics is physics, you must alter the anatomical target.
You have to change the eye. Which leads us to the first major category of workarounds detailed in this review: physical thickness manipulation. And the logic here is brilliantly pragmatic. If the rule is, you must be 400 microns tall to ride this ride, surgeons just figure out how to artificially puff the eye up just long enough to run the UV light.
It was the first logical pivot. The most prominent early attempt was the hypoosmolar technique, which was heavily researched by Hafezi around 2009.
How does that work?
Well, the standard riboflavin solution used in the Dresden Protocol contains dextran. Dextran is a large polymer that acts as an osmotic agent to keep the cornea at its normal hydration level, an isoosmolar state.
Okay, so it keeps the water balance neutral.
Exactly. So Hafezi's team removed the dextran. They formulated a hypoosmolar riboflavin solution, dropping it to around 310 milliosmoles per liter.
By removing that osmotic pressure gradient, the solution suddenly forces fluid into the dehydrated stroma, right? It intentionally induces acute corneal edema.
Yes, they purposefully swelled the thin corneas, puffing them up with fluid until they crossed that 400 micron safety threshold. And only at that point would they initiate the UVA irradiation.
And according to the review, it worked to a degree. Hafezi's initial studies showed stable topographic changes at a 6-month follow-up without widespread endothelial decompensation. So they successfully protected the back of the eye.
They did shield the endothelium, yes. But the clinical community quickly identified a severe biochemical trade-off.
There's always a catch.
Always. Inducing edema fundamentally alters the spatial relationship of the collagen matrix.
Oh, because you're pumping water between the fibers.
Exactly. When you artificially hydrate the stroma to that extreme, you physically push the collagen fibrils further apart. The literature refers to this as creating collagen-free lakes within the tissue.
Collagen-free lakes. That makes perfect sense. The reactive oxygen species have an incredibly short half-life and a tiny radius of action. If you swell the tissue, the collagen fibrils have just floated too far away from each other for those chemical bridges to actually form.
That is the exact biomechanical failure point. There is simply a lower density of collagen fibrils available within the interaction radius of that singlet oxygen.
So they just fizzle out before they hit anything.
Right. Furthermore, the massive influx of fluid drastically alters the oxygen diffusion gradient. Oxygen does not diffuse through an edematous, waterlogged cornea nearly as efficiently as it does through a normal, compact stroma.
So the chemical reaction is starving for oxygen, and the fibers are too far apart to link up anyway. You get a significantly weaker structural reinforcement.
A much weaker effect.
And the review notes that to actually halt the bulging of keratoconus, you need a critical mass of cross-linked tissue, something like at least 250 microns of effectively stiffened stroma. But because the hypoosmolar swelling yields such a shallow, weak effect, doctors still had to advise a minimum pre-op thickness of 330 microns.
Right. It didn't solve the problem for the truly ultra-thin corneas, the ones down in the 200s.
Which forced researchers to look beyond internal hydration. If internal swelling compromises the fibril density, the next logical step is external augmentation. Like, how can we add physical mass to the outside surface of the eye without disrupting the internal stroma?
And that brought about contact lens-assisted cross-linking, or CXL. This was pioneered by Jacob in 2014.
And from a purely mechanical standpoint, it is incredibly straightforward. You perform the standard epithelial debridement, you soak the stroma with standard riboflavin, and then right before you turn on the UV light, you take a specialized riboflavin-soaked bandage contact lens, usually about 90 to 100 microns thick, and you just lay it directly over the thinned stromal bed.
You are artificially constructing a temporary roof over the stroma. The goal is to ensure the total distance from the light source to the endothelium meets that absolute 400 micron requirement.
And early clinical data on a small cohort, I think it was 14 eyes, showed it was generally effective at stabilizing the topography.
It was, but let's pause on that mechanism for a second because there's a big problem there too.
Yeah, I was thinking about this. The entire procedure relies on precise ultraviolet photochemistry. Doesn't placing a synthetic polymer lens directly over the target fundamentally interfere with the transmission of both light and atmospheric oxygen?
You're touching on the exact limitation that Dubey and Chowdhury highlight. The bandage contact lens is a substantial physical barrier. While it achieves the goal of increasing functional thickness, the polymer matrix of the lens absorbs a massive percentage of the UVA radiation.
How much are we talking?
Studies demonstrated that the lens reduces the surface irradiance level, reaching the actual stromal bed by 40 to 50%.
Wow. You are losing half of your chemical catalyst just penetrating the plastic shield.
Yes. And similar to the hypoosmolar technique, that synthetic barrier severely restricts the diffusion of ambient oxygen into the tissue. The contact lens effectively suffocates the photochemical reaction.
It's like putting a lid on a fire.
Exactly. You are starving the stroma of the two primary variables required for ROS generation, sufficient photon energy and molecular oxygen.
So it's a blunt force solution that really dampens the entire efficacy of the procedure. But this sets up what I think is the most fascinating, almost sci-fi technique in the entire review, the SMILE lenticule-assisted technique.
Documented by SOCDEV in 2019.
Yes, and this is where we get into actual biological upcycling. Here's where it gets really interesting.
It is a remarkable convergence of two entirely different refractive surgical disciplines. To understand it, we must first look at the SMILE procedure itself.
Right. SMILE, which stands for small incision lenticule extraction, is a laser vision correction surgery. It's similar in goal to LASIK, but used primarily for myopia or nearsightedness.
Right.
During SMILE, a femtosecond laser carves out a microscopic disc-shaped piece of healthy stromal tissue from the middle of the patient's cornea. The surgeon pulls this disc, the lenticule, out through a tiny incision, which flattens the eye and corrects the vision. And traditionally, that healthy lenticule is just thrown away as medical waste.
But SOCDEV recognized that this quote-unquote waste material is actually biologically pristine, optically clear human corneal stroma.
It's perfectly good tissue.
Exactly. So in the lenticule-assisted CXL technique, they harvest that healthy lenticule from the myopic donor, they cryopreserve it if necessary, and they use it as the external biological shield for the keratoconus patient.
Instead of a plastic contact lens, they drape a custom-cut piece of donor human cornea directly over the thinned apex of the keratocon eye before applying the UV light.
When you analyze the biophysics of this, it resolves almost all the interference issues of the contact lens because the lenticule is structurally identical to the underlying host stroma.
Right. It's literally the exact same material.
Exactly. So it possesses the exact same UV absorption coefficients and oxygen diffusion properties. It doesn't block the light or suffocate the tissue in an unnatural way. It simply acts as a seamless extension of the host's own cornea.
It's a perfect biologically invisible patch. And what's brilliant is that during the donor's smile surgery, the laser dictates exactly how thick that lenticule is going to be.
Right, it's programmed.
So if the keratoconus patient has a cornea that is, say, 320 microns thick, the surgeon can specifically request an 80-micron lenticule to perfectly hit that 400-micron safety limit.
The precision is highly elegant. However, the review rightly points out the logistical reality of doing this.
I can imagine. It sounds complicated.
It is. Implementing this requires an advanced surgical infrastructure. You need a steady pipeline of SMILE procedures to harvest from. You need sophisticated eye bank protocols for serological testing and cryopreservation to prevent disease transmission.
Right, you can't just pass tissues between people without testing.
Exactly. And you need highly skilled surgeons to flawlessly align the lenticule over the host's cone. It is brilliant science, but difficult to scale globally.
Which naturally leads the field to rethink the paradigm completely. If artificially adding thickness, whether with water, plastic, or donor tissue, is so fraught with chemical or logistical compromises, why not re-examine the very first step of the Dresden Protocol?
You're referring to the debridement.
Yes. Why are we throwing away the eye's natural 50-micron protective shield in the first place?
Ah, the epithelium.
Exactly. If you just leave the epithelium on, you instantly preserve about 50 microns of vital biological safety buffer. Furthermore, stripping that cellular layer is the primary cause of the severe, excruciating postoperative pain patients experience.
And it's the main vector for postoperative microbial keratitis or infection.
Right, so the clinical appeal of a transepithelial or epi-on approach is massive. Painless, non-invasive cross-linking. But as we established earlier, the epithelium's primary biological mandate is to act as an impermeable barrier to large hydrophilic molecules like riboflavin.
So to achieve an epi-on CXL, doctors had to turn to heavy chemical engineering. They had to figure out how to chemically force the epithelial barrier to become leaky without physically scraping it away.
And the review details the use of several chemical permeation enhancers, right?
Yes. The most prominent are benzalkonium chloride, often abbreviated as BAC, EDTA, gentamicin, and trimetamol.
Let's drill into the cellular mechanics of that, because it's not just magic drops you put in the eye. The epithelium is heavily fortified with tight junctions between the cells, and the cell membranes themselves are lipid bilayers. How does something like BAC actually break that down?
Well, benzalkonium chloride is a quaternary ammonium compound. It essentially acts as a powerful surfactant or detergent.
Soap.
Very much like soap. When applied to the corneal surface, the lipophilic portion of the BAC molecule inserts itself into the lipid bilayer of the epithelial cell membranes. It disrupts the highly ordered lipid structure, essentially dissolving the tight junctions and creating micropores in the cellular barrier.
Okay, so it punches microscopic holes in the skin.
Basically, yes. This artificial porosity allows the riboflavin molecules to slowly seep down into the stroma.
Okay, so they chemically pry the doors open. But reading the clinical outcomes in the review, this approach suffers a massive drop in efficacy.
A profound drop. And the reason comes back to the photochemistry. Even if you successfully force the riboflavin into the stroma, the physical mass of the epithelium is still sitting on top of the eye during the UVA irradiation phase.
And it's not transparent to UV.
No, the epithelium is packed with UV-absorbing cellular components, nucleic acids, ascorbic acid, proteins. It acts like a highly effective UV sponge.
So it's absorbing the photon energy before it can even trigger the oxidative reaction in the deep collagen where the bulging is actually happening.
Precisely. Additionally, the intact epithelium acts as a significant barrier to oxygen diffusion, once again starving the reactive oxygen species generation.
So we're back to starving the fire.
Yes. And the resulting biomechanical data is stark. Standard, Epi-Off CXL, where you physically scrape the surface, increases the biomechanical rigidity of the cornea by approximately 320%.
320%. That is a massive, highly successful structural fortification.
It is. In contrast, studies on transepithelial Epi-on CXL show that rigidity only increases by a meager 64%.
Ouch, you lose almost the entirety of the structural benefit just to save the patient from a few days of surface pain.
And that translates directly into surgical failure rates. The review cites a major 2017 study by Juve evaluating long-term outcomes.
What did that study show?
The Juve study is highly illuminating. Over a 2-year follow-up, the failure rate, which is defined as continued topographic progression of the keratoconus, was 20% for the Epi-on cohort.
1 in 5 failed.
Yes. Compare that to a failure rate of just 7.5% for the conventional Epi-Off group. Leaving the epithelium intact simply fails to deliver sufficient cross-linking density.
But the appeal of a painless, non-invasive procedure is too strong for the field to completely abandon. If chemical surfactants like BAC couldn't push enough riboflavin through the barrier, researchers looked toward physics, specifically electromotive force.
Which led to iontophoresis CXL, or ICXL, published by Bikbova in 2014.
Right, and iontophoresis is a brilliant application of electromagnetism to solve a biochemical diffusion problem, because riboflavin, in its physiological state, is a negatively charged molecule.
Right. So instead of relying on passive diffusion or chemical detergents to slowly seep the negatively charged riboflavin through the epithelium, they use an electrical circuit to actively pull it through.
I compared this in my head to using a power washer instead of garden hose to get soap into a sponge.
That's a fun way to look at it.
The setup requires placing a return electrode on a distal part of the patient's body, typically the forehead or the cervical vertebrae. And then a specialized suction ring containing the active electrode is placed directly onto the cornea.
And that ring is filled with the riboflavin solution.
Right. And then they run a continuous 1 milliampere electrical current through the eye for 5 minutes. The negative electrode in the suction ring repels the negatively charged riboflavin molecules, driving them aggressively down through the intact epithelial tight junctions and deep into the stroma.
It's essentially a magnetic push-pull system forcing the drug into the tissue.
It is a highly efficient delivery mechanism. The active electromotive force bypasses the need for debridement, and crucially, it reduces the necessary riboflavin soaking time from 30 grueling minutes down to just 5 minutes.
Which is a massive win for the patient's experience in the OR. But, as the review points out, you still run into the exact same photochemical bottleneck during the irradiation phase.
The skin is still there.
Exactly. You've successfully loaded the stroma with riboflavin, but the intact epithelium is still sitting there, acting as a UV sponge and blocking the ambient oxygen.
The laws of optics and gas exchange remain undefeated.
They really do. While iontophoresis showed some promise in halting progression for very early mild keratoconus, it simply cannot generate the depth and density of cross-linking required for advanced, aggressively thinning corneas. The barrier remains a barrier.
Which naturally birthed perhaps the most literal manual compromise in the entire history of this procedure, the epithelial island technique.
Ah, yes.
This was explored by Mazada in 2014 and Kagel in 2017, and the logic here is just fascinating.
It represents a highly targeted topographical approach to debridement. The surgeons understand the absolute necessity of removing the epithelium to achieve that 320% strength boost.
Right.
But they also know that in keratoconus, the thinning is not uniform across the whole eye. There is a specific, localized apex, the tip of the cone, where the stroma is dangerously thin and the endothelium is at peak risk.
So instead of scraping the entire surface, they perform a customized manual debridement. They scrape away the epithelium from the mid-periphery of the cornea, but they intentionally leave a tiny, localized island of intact epithelial cells perfectly centered over the absolute thinnest point of the cone.
The intention is to utilize the epithelium's natural UV-absorbing properties solely at the point of maximum vulnerability. You get deep, robust cross-linking everywhere else to stabilize the overall structure, while utilizing the intact island to shield the delicate endothelial cells directly beneath the cone.
But wait, think about the structural physics of that for a second.
Okay.
The apex of the cone is precisely where the stroma is weakest and bulging the most. If you leave the epithelium intact over that exact spot, aren't you intentionally dampening the cross-linking effect right where the eye needs structural reinforcement the most?
That is the precise biomechanical flaw of the island technique. and the clinical data confirms your suspicion perfectly. Postoperative optical coherence tomography demonstrated a highly uneven demarcation line.
Meaning the cross-linking was patchy.
Yes, meaning the depth of the cross-linking effect was robust in the periphery, but dangerously shallow directly beneath the island. You are effectively leaving the structural keystone of the bulge undertreated.
And the irony is, according to the review, it didn't even perfectly protect the endothelium. Some authors still reported significant endothelial cell density loss directly under that island.
It is a prime example of a core medical reality. Whenever you prioritize procedural convenience or attempt to manually cheat a hard biological requirement, you invariably sacrifice clinical efficacy. The photochemistry demands unimpeded access to light and oxygen.
Which pivots the entire conversation. Because if physical patches block light, if chemical surfactants fail, and if partial scraping creates weak spots, well, you cannot change the anatomy. You have to change the physics of the light delivery itself.
Exactly.
This is where the field starts manipulating the variables of time and irradiance to protect thin corneas without sacrificing the reaction.
To understand how surgeons began manipulating the laser, we must look at a foundational rule of photochemistry, the Bunsen-Roscoe law of reciprocity.
And this law is the absolute backbone for what the field calls accelerated CXL. The Bunsen-Roscoe law states that the extent of a photochemical reaction is directly proportional to the total energy delivered, regardless of how you divide the time and the intensity.
It is a concept heavily utilized in traditional film photography exposure, if you're familiar with that.
Right.
You can achieve the exact same total energy delivery, what we call the total fluence, by using a low-intensity light for a very long time or high-intensity light for a very short time.
So let's apply the math to the Dresden protocol. Wollensak used an intensity of 3 millirats per square centimeter for 30 minutes. That results in a total delivered fluence of 5.4 joules per square centimeter.
And according to strict reciprocity, a surgeon is not tethered to a 30-minute procedure. You could triple the irradiance to 9 milliwatts per square centimeter, and the math dictates you only need 10 minutes to deliver that same 5.4 joules.
Or go even faster, right?
Theoretically, yes. You could crank the laser to 30 milliwatts per square centimeter and finish the entire irradiation phase in a mere 3 minutes.
The mathematical fluence is identical. But human biology is not photographic film. The review details a massive fundamental biological bottleneck that ruins the math when you accelerate the light too fast. And it all comes back to oxygen depletion.
Yes, the oxygen diffusion limit. To really understand this, we have to look closely at the two distinct photochemical pathways that occur during cross-linking, type I and type 2.
Let's break those down because this is where the actual stiffening happens. What's the difference?
In a type I reaction, the UV-activated riboflavin reacts directly with the organic substrate, the collagen to form radicals, which then cross-link. This pathway is relatively oxygen independent.
Okay, so it doesn't need breathing room.
Right. However, the type 2 pathway is where the vast majority of the biomechanical stiffening occurs. In type 2, the activated riboflavin interacts directly with molecular oxygen dissolved in the tissue, creating those highly reactive singlet oxygen species we discussed earlier.
So type 2 is the primary engine of the procedure, and it is entirely dependent on a constant supply of oxygen.
Precisely. Now, when you utilize the slow 30-minute Dresden protocol at 3 milliwatts, the creation of singlet oxygen happens at a steady, manageable rate. As the oxygen in the superficial stroma is consumed, fresh ambient oxygen from the operating room air has enough time to passively diffuse down into the tissue and replenish the supply.
The reaction burns slowly and deeply.
Yes, but when you accelerate the protocol, when you blast the cornea with 9, 18, or 30 milliwatts, you hyperstimulate the type 2 pathway. You generate reactive oxygen species so violently and rapidly that you instantly consume every single molecule of oxygen within the stroma.
Wow. You create an acute hypoxic event. An oxygen desert.
The rate of consumption massively outpaces the rate of passive atmospheric diffusion.
And once the oxygen is gone, the type 2 reaction simply shuts down no matter how much UV energy you continue to pump into the eye.
Exactly. The clinical manifestation of this oxygen starvation is what the literature refers to as a prematurely shallow demarcation line.
Meaning what?
It means you achieve aggressive cross-linking in the very superficial anterior stroma where oxygen is immediately available. But the deeper stromal layers, which are critical for halting the keratoconic bulge, they remain completely untreated because the oxygen ran out before the reaction could propagate downward.
It perfectly mimics the physics of trying to bake something at an impossibly high temperature.
Oh, that's a good analogy.
Like if the recipe calls for 350 degrees for an hour, you cannot bake it at 700 degrees for 30 minutes. The intense, rapid heat sears the outside to a crisp instantly, creating a crust that stops the thermal transfer, leaving the entire center of the cake completely raw.
Exactly.
Accelerated CXL at 30 milliwatts sears the surface and leaves the deep stroma raw.
That thermal analogy captures the diffusion barrier perfectly. The energy cannot penetrate because the medium, in this case oxygen, is exhausted. So to salvage the accelerated protocols and actually save time in the OR, researchers had to find ways to artificially manage the oxygen gradient.
And the most prevalent solution detailed in the text is pulsed fractionation.
Yes, pulsed CXL. It's a direct mechanical response to the oxygen depletion problem. Instead of firing a continuous beam of high-intensity UV light, the laser is programmed to pulse on and off at specific intervals.
Like a strobe light.
Basically, for example, 1 second on, 1 second off.
By creating those microscopic off periods, the surgeon is essentially letting the tissue catch its breath. The UV light pauses just long enough to allow ambient oxygen to passively diffuse back into the depleted stromal layers before the next blast of energy consumes it again.
And it works. It significantly improves the depth of the demarcation line compared to continuous accelerated protocols. And for surgeons who want to push the acceleration even further, the review notes the advent of supplemental oxygen delivery.
This part is wild to me. They literally place specialized goggles or a modified speculum over the patient's eye and flush the surgical field with a continuous flow of high concentration, greater than 99% pure oxygen.
It is brilliant. By artificially supersaturating the atmospheric environment immediately anterior to the cornea, they drastically steepen the concentration gradient.
Which forces the oxygen down.
Yes, forcing oxygen into the stroma at a much higher rate. This allows the type 2 photochemical reaction to run at high speeds without suffocating.
It is an incredible balancing act of physics, timing, and gas exchange. And synthesizing all of this data, the general clinical consensus seems to be that a moderately accelerated protocol, specifically 9 milliwatts per square centimeter for 10 minutes with the epithelium removed, is the accepted sweet spot.
Right. It provides a meaningful reduction in surgical time without severely compromising the depth of the cross-linking.
But again, even a 10-minute protocol at 9 milliwatts relies on standardized assumptions about stromal depth. For the truly ultra-thin corneas, those measuring down in the 200-micron range, even these optimized, accelerated protocols risk endothelial damage, which brings the field to its most recent and arguably most sophisticated evolutionary leap.
We have arrived at the bleeding edge.
We've spent this entire deep dive looking at how surgeons tried to bend the rules to fit a standardized protocol. Swelling the eye, cutting smile lenticules, pulsing the light. But the final phase of this evolution throws out the standardized protocol entirely. This is the era of the pinnacle of customization.
We are witnessing the transition from rigid, generalized medical guidelines to hyper-individualized, mathematically modeled treatment algorithms.
And the first major breakthrough in this bespoke era, detailed heavily in the review, is the sub-400 protocol. Developed by Hafezi's group and published around 2021, this protocol was engineered from the ground up specifically for those highly vulnerable ultra-thin corneas measuring between 214 and 398 microns.
The defining characteristic of the sub-400 protocol is its reliance on real-time intraoperative biometry.
What does that mean in practice?
Well, previously, surgeons relied heavily on preoperative thickness measurements taken in the clinic days or weeks before. But as we discussed, the act of debridement and the application of riboflavin inherently alters the stromal thickness.
The eye shrinks on the table.
Exactly. So in the sub-400 protocol, the surgeon halts everything immediately before applying the UV light. They use a handheld ultrasound pachymeter to measure the exact, down-to-the-micron stromal thickness at the thinnest point of the cone at that precise moment.
They acquire the absolute truth of the anatomical battlefield right then and there.
Beautifully put.
And once they have that real-time measurement, they don't rely on intuition or a standard 10-minute timer. They consult a highly specific, empirically derived treatment algorithm. The review actually provides the data from Table 2 of Hafezi's study, and it is a fascinating look at precision medical math.
It acts as an exact prescription map, correlating specific stromal depths to precise durations of UVA irradiation.
Let's look at the actual numbers from Table 2 to see how tightly controlled this is. Say the surgeon's intraoperative ultrasound reveals the stroma is a terrifyingly thin 200 microns, half of the old Dresden requirement.
Very dangerous territory.
Right. So they check the sub-400 table, and it dictates that they deliver standard 3 milliwatt UV light for exactly 1 minute, not 30 minutes, not 10 minutes, 60 seconds.
And The photochemistry modeling guarantees that 1 minute of irradiation at 3 milliwatts will result in a demarcation line, the absolute floor of the cross-linking effect of precisely 130 microns deep.
Which is the magic number. Because if the cornea is 200 microns thick and the treatment stops at 130 microns, it leaves exactly 70 microns of pristine, untreated stroma acting as a perfect biological shield for the endothelium.
And the precision scales up perfectly. If the ultrasound pachymetry measures 270 microns, Table 2 dictates an irradiation time of exactly 4 minutes. The photochemical reaction will penetrate to a depth of 200 microns, halting perfectly to leave that exact same 70-micron safety buffer.
It is stunningly precise, and the clinical outcomes validate the math. The Hafezi study demonstrated that this sub-400 protocol was successful in halting disease progression at the 1-year mark in 90% of keratoconus patients presenting with these ultra-thin corneas.
And most critically, out of all those high-risk eyes treated, there was a 0% incidence of endothelial decompensation. Absolutely no toxic damage to the inner cell layer. They completely neutralized the catch-22 that had plagued the field for decades.
Zero damage. They mapped the photochemistry so perfectly that they could thread a microscopic needle. But the review highlights one more conceptual leap that goes even further than Hafezi's table, the M protocol.
Proposed by Mazada in 2018. The authors refer to this as the ultimate culmination of CXL research.
If the sub-400 protocol is a highly specific lookup table, the M protocol is a dynamic, multivariable mathematical engine. Mazada recognized that cross-linking depth isn't just a function of time.
Right, there were so many other factors.
Exactly. It's influenced by irradiance intensity, oxygen concentration, riboflavin diffusion rates, and the specific topographic curvature of the individual cone.
So Mazada aggregated all the available empirical data, every study on demarcation lines, every oxygen depletion curve, every failure rate, and integrated it into a master nomogram.
A nomogram is essentially a graphical calculating device, right? Like a predictive model.
Yes, a model that allows a surgeon to input a multitude of independent physiological variables to generate a highly specific, preset photooxidative depth.
It calculates exactly what custom combination of pulsed light, intensity, and time is required for any given eye, regardless of whether it is an ultra-thin 200 microns or a relatively healthy 450 microns. The M protocol standardizes the customization process itself.
It allows the surgeon to dictate the exact depth of the treatment before the laser is even turned on, sparing the endothelium while guaranteeing sufficient cross-linking volume to arrest the ectasia. However, we must view this through a lens of clinical reality.
Right, the technology barrier.
Precisely. Executing the M protocol requires an immensely sophisticated surgical suite. It demands top-tier ultrasound pachymetry, advanced UV lasers capable of highly calibrated pulse fractionation, and integrated supplemental oxygen delivery system.
Which is incredibly expensive.
Highly expensive. That level of infrastructural investment is simply not accessible to the vast majority of clinics globally, particularly in developing healthcare systems where keratoconus is often highly prevalent.
It's the bleeding edge of medical science, which inherently means it's not yet equitable. But as a proof of concept, the sub-400 and M protocols represent the ultimate triumph over the rigid limitations of the original Dresden era. By deeply mathematically understanding the variables of their own tools, the diffusion rate of oxygen, the fluence of the photons, the molecular density of the collagen doctors have figured out how to safely treat the exact patients who just a decade ago were sent home with no hope.
It is a profound paradigm shift. It moved the entire discipline from a framework of rigid exclusion to one of dynamic inclusion, driven entirely by methodical, iterative scientific inquiry.
Which brings us to the close of this incredible narrative. If you step back and look at the trajectory we've unpacked today from Dubey and Chowdhury's review, it is a masterclass in medical resilience.
It truly is.
We started in 2003 with a rigid 30-minute Dresden protocol that demanded a 400-micron stromal bed, a rule that tragically excluded the most advanced, vulnerable cases of keratoconus. We watched as surgeons tried to physically hack that rule, swelling the stroma with hypoosmolar fluids, which only pushed the collagen fibers too far apart.
We saw the attempt to use synthetic contact lenses, which inadvertently blocked the vital UV irradiance and starved the tissue of oxygen.
We marveled at the biological ingenuity of upcycling SMILE lenticules, using customized patches of donor human tissue to build the perfect biological shield. We explore the chemical warfare of epion techniques, using heavy surfactants like BAC to break down lipid bilayers,
Right.
and the electromagnetic wizardry of iontophoresis to pull riboflavin through intact skin, only to realize the epithelium is an insurmountable UV sponge.
We analyze the biophysics of the Bunsen-Roscoe law, uncovering the massive oxygen bottleneck that occurs during accelerated protocols, and the clever mechanical solutions of pulsed UV light and supplemental oxygen to let the deep stroma breathe.
And finally, we arrived at the modern marvel of personalized medicine. Mathematically precise, ultrasound-guided algorithms like the sub-400 protocols that tailor the photochemistry to the individual micrometer.
What stands out most profoundly from this review is the realization that in the realm of clinical science, a physiological limitation is rarely a hard stop. It is almost always an invitation for further innovation.
Absolutely.
The evolution of cross-linking proves that when faced with a biological wall, you don't stop treating the patient, you simply re-engineer the physics and chemistry of the tool until the wall becomes a door. It is a testament to questioning standard assumptions.
I couldn't agree more. And as we wrap up, I want to leave you, the listener, with one final thought to explore on your own. Throughout this deep dive, we've seen how doctors have learned to masterfully manipulate light, atmospheric oxygen, and even recycled human lenticules simply to freeze a bulging cornea in place. They have perfected the art of halting the destruction. But as topographic mapping, algorithmic customization, and tissue bioengineering become even more unbelievably precise, you have to wonder about the next logical leap. Will the future of this science move beyond merely halting the damage? Could we soon see a convergence of ultra-customized, topographically linked UV light patterns, paired perfectly with synthetically bioengineered lenticules that don't just stop the progression of the cone, but actually shrink, tighten, and resculpt the diseased cornea back to its original, perfect optical shape?
We have spent 2 decades learning how to perfectly freeze the architecture. The inevitable next frontier is learning how to actively rebuild it.
Thank you for joining us on this deep dive into the resilient, endlessly fascinating biophysics of the human eye. Keep questioning the boundaries of the science around you, and we will catch you on the next one.